The end schedule care team is a new idea, and it's looking to support practices in ways that they can manage their daily workload and looking at it in a different way. So the way that we're helping the current surgery that we're based in is that we're taking off from them people that are needing to be seen on the day. So rather than them phoning up and then all the appointments have gone, to be put onto a triage list where at the moment I'm the person that's phoning them back. We do also have triage nurses who are helping with that role, so that we are working then as a team to triage those patients so that they are put into the most appropriate place or given advice and finished at that point. What happens with the house calls is that anybody who's requesting a home visit gets put onto the home visit list. Before we as a team started, that list would then be just divided up to the duty doctors of the day, and it tends to wait until after morning surgery. The way that this team is different is that the people still get put onto the list. I then phone back everybody that's wanting a home visit so that we're making sure that it's appropriate, that whether we need a district nurse to attend, whether the doctor needs to go, or whether we can use one of the paramedic practitioners from our team and whether they can go and see this person.
I'm a degree trained nurse and I have 4 years experience in cardiac care and additional 4 years experience in accident and emergency, initially working as a band 5 staff nurse and then progressing to level of a band 6. Since then I've joined the ambulance service and was one of 4 nurses to do a conversion programme to gain my paramedic qualification. I've now been qualified as a paramedic for approximately 4 years, and during that time I've undertaken my Masters in Advanced Practice.
Where we're fortunate in both health board areas and within my own trust is that we have very forward-thinking chief execs who quite clearly recognise the pressure that GPs face. The ability of practitioners to do, for example, house calls, which allows GPs to concentrate on more serious cases within the practice, is seen as key to successful delivery of primary care.
The only ones currently we're not doing are the palliative care patients. Anyone else we will go out to see. Any problems we have we'll discuss with the doctor, but in doing those visits we're able to take pressure off the GPs in the surgery. For an example, yesterday I did 7 house calls. The GP had to do 4, so had we not been there they would have had to do 11 house calls during that day.
Obviously, from an ambulance perspective, we want our advanced practitioners to be at the highest clinical level that they possibly can be, and that can only be achieved by a forward-thinking GP actually mentoring and supporting the practitioners, and that's the key element. One, it gives the GP confidence that the practitioner going out to do house calls is competent and able to, for example, independently prescribe, but more importantly gives the community the confidence that they're not always going to be seen by a GP, they're going to be seen by another health professional, and in many cases that will be an advanced nurse paramedic practitioner or simply an advanced paramedic practitioner.